A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors. Why do so many people need knee or hip replacement surgery? Our guests today say it's a combination of age, arthritis, and genetics. On average, the time it often becomes necessary is by age 62. Stay with us as our medical experts tell us about the latest techniques for knee and hip replacement and how they can help defy genetics with some great lifestyle tips. All on this edition of your Hometown Health Connection. I'm John DeSciullo. Samantha Latshaw is on assignment, and welcome to your Hometown Health Connection. Now, if you or someone you know needs a knee or hip replacement, then this next half hour may change your life as we meet a husband and wife who are physicians with a special team approach to treating their patients. Dr. Marcus Romanowski has been in practice since 1998. He has built an expertise in outpatient knee and hip replacement surgery. Dr. Marcus, along with his wife, Dr. Cindy Romanowski, have created a unique orthopedic practice. Working together, they have developed a comprehensive continuum of care from preoperative education through surgery to a customized post-operative physical therapy plan for all of their surgical patients, resulting in better overall outcomes, less complications, and accelerated recovery rates. Over the last 20 years, Dr. Cindy Romanowski has become a leader in pre- and post-operative patient education and physical rehabilitation. She and Dr. Marcus Romanowski have established a unique practice that provides coordinated care in preoperative education, surgery, and physician-supervised home rehabilitation programs. Dr. Cindy and Marcus Romanowski, welcome to your Hometown Health Connection.
Thank you.
Thanks. So, Dr. Marcus, can you tell us when a person might need knee or hip replacement surgery? What triggers that?
Yeah, most people, it's a functional loss when people can no longer do the things that they want to do. You have a woman that wants to help take care of her grandchildren, but she has to be able to go up and down stairs predictably to do that. You have someone that wants to continue working, but they're finding that the commute to work and getting in and out of the workplace is becoming more challenging. Or recreationally, they can't play golf. You know, they can do 9, but they can't play 18 holes of golf. So you get to the point where you're limited in what you want to do, and conservative measures are no longer effective. So the simple things are no longer working, and then maybe it's time to think about a real solution with a joint replacement.
Right, to feel better and enjoy life as you've lived it all along.
Yes.
Yeah. So Dr. Cindy, we'll ask you, what is your role in the joint replacement care?
When patients initially call our office for a consultation, they're always seen by Dr. Mark and his team. We're never in the office at the same time. So he does the initial evaluation, and patients will be on one of a couple different paths. Some patients may be needing surgery right away. Some people may just need some follow-up care, and some patients may need more conservative measures. So when patients just need conservative management and injections and therapies and that type of thing, patients would be coming to my office hours.
And you have a great interpersonal approach with your patients. So Dr. Marcus, what is involved with the knee or hip replacement? And what I ask by that is, like, what materials are used and the different types of procedures to work on the knee and the hip?
Well, each procedure is roughly about an hour long. Fortunately, there's been a great advancement over the past few years, primarily with pain relieving medications and surgical technique that allows these procedures to be done without a formal hospitalization. So a patient will come into the hospital or a surgery center. They'll have their roughly 1 hour long surgery, which essentially is a resurfacing of the joint. The damaged portions of the joint are removed, and then metal and plastic, ultra high molecular weight polyethylene, those surfaces are then applied to replace the joint. And then shortly after the procedure, we'll get the patient up and walking within an hour or so. And we get them back on track towards getting back to being functional.
Are there different types of medical procedures, different types of surgeries?
Sure. I mean, there's all different kinds of surgeries, but essentially for knee and hip replacement, the final determination of the procedure will be based on the patient's physical exam, their history, and specifically what they need done. But most patients fall into a category where they can consider having an outpatient surgery or perhaps a short stay overnight in the hospital one night and then home the next day. Most people fall into that category. There may be some more complicated cases with extenuating circumstances, but most people can consider that now.
It's great if it's the same day or just within a few days. That's terrific. So Dr. Cindy, I'll ask you this. Are there intermediary measures that can be taken, like when a person is experiencing hip or knee pain prior to surgery, such as injections? Tell us a little bit about that.
Yeah, I do a lot of injections in the office. When patients come to see Dr. Mark, there are a lot of moving parts and people are getting x-rays and scheduling surgery. So when patients get onto the conservative pathway, they can come see me for cortisone injections. And I have a lot of patients that just want to come in for an injection every 3 or 4 months or so. So when they leave the office that day, they just get set up to come in the next time because they know if they try to stretch it any longer than that, then they can't make it. So they kind of get in the queue. So I do a lot of cortisone injections in the office, and I also do a lot of viscosupplementation, which are otherwise known as gel shots. And that's a series of 3 injections the patients would get 3 weeks in a row, and they can do those every 6 months.
So Dr. Cindy, how long would those procedures take in the terms of not only in your office, but also the time spent? Is there a predicted amount of time? Does it depend on the patient where they would be getting those injections?
When patients come in the office, when they come on my day, because I have a very regimented schedule, they really come in and out of the office pretty quickly. Also, I try to be cognizant of patients' times. I have a lot of patients that are 90 years old that are waiting for the van, and usually I just tell the van to wait because they're going to be in and out of there before they can make their next stop. And I do the viscosupplementation injections under ultrasound, and a lot of patients are kind of worried to come in for them. Does it hurt? And I'm usually putting the Band-Aid on by the time they're done worrying about it. So they get in and out of the office pretty quickly because it's predictable.
Yeah, and with that, is it a few months that they'd be getting some of these injections?
The cortisone shots we can do every 3 or 4 months. The viscosupplementation, you have to wait 6 months in between because the insurance carriers have to authorize everything.
And is that something where if you get the injection, can that help the person move forward without having surgery, or does that generally lead to the surgery?
It can put things off. I have a lot of patients that do the injections that are in their 80s or 90s because they just simply don't want to have surgery. They're not surgical candidates. I have patients in their 50s that may do this for a couple of years because they need to put off the surgery till they have a chunk of time that they can actually do the recovery. And I have some patients that have been getting these injections for 10 years.
Right. So Dr. Marcus, when a patient comes to see you, how do you determine in the exam what they need, whether it's a knee or hip replacement?
Sure. Well, most important, first thing we start with is history. We actually ask patients to fill out a fairly extensive history form, just communicating to us their limitations and their other medical problems as well. So when I see them in the office, we'll go over their history. They'll tell me about their symptoms, their pain, how long it's been going on, what they can't do. Maybe their other medical problems play a role in this as well. Then we'll do some x-rays. So we'll take x-rays of either the hip or the knee to look at the amount of destruction that's in the joint. Sometimes patients can have a fair amount of symptoms, but the process is still early. Those patients are better served by therapy or maybe some medications or injections with Cindy. If the joint is really well on its way to being damaged and destroyed, then we'll do a physical exam. We always do a physical exam, but the physical exam in those patients will show more marked limitations in range of motion, and then we have a better idea of what they're going to get, what they're going to gain by having the joint replaced. Because another, pain relief is one major reason to do the joint replacement, but range of motion is another. We want to restore that functional ability so that they can, get down on the floor and crouch in a corner or go up and down stairs or get in and out of the golf cart, that kind of thing.
Do you find, Dr. Marcus, I'll continue with a quick follow-up, that people of a certain age maybe just resign themselves to the fact that this is how I feel and it's a function of age and that's how it's going to be? I would imagine you would encourage them not to think like that, but to come in and see you for this exam. And
yeah, sometimes, people are good at making accommodations, and so this is actually an aspect of our practice which I think Cindy helps me a lot in terms of patients are fearful about surgery, and you come in and I'll explain to them the process, and they might still be hesitant about it. But let's say then they come back and they see Cindy for a period of months or whatever, getting therapy or injections. And it's another opportunity to talk with the provider about what is this joint replacement experience? How many months am I expecting to spend recovering, and what am I really going to gain at the end of it? So we have a lot of patients that are in the practice for many years before they make the decision to have surgery. But I think ultimately most people get to the point where their pain is such and their limitations are such that it's a relatively easy decision to make.
The decision is almost made for them. Dr. Cindy, there's a team approach. First of all, your husband and wife, so there's a great team there. Talk to us about that team approach, which you touched on a little bit, Marcus, but how does that work for the patient?
Well, there are a couple teams. Mark has the team in the OR, we have the team in the office, and we have therapy teams. But I think when people decide to have surgery, the first thing that's really important is the patient education. I think all of this starts with the education before we even get to the team. So when patients register for surgery with us, our surgery scheduler gives them a packet, which I designed, and in it there's a 6-page outline of everything you need to know. There's also an invitation to a preoperative education class that I do. There's maps to which door you're going to go in the hospital. I give a pre-op education sheet for exercises. And then when patients are set up to come to my class, the class usually is a month or 2 before surgery. We like to get them in as soon as possible so they can start doing their exercises. And in that class, I go over everything you could possibly know about the surgery. We go over how to do the pre-admission testing, what exercises you need to do, what therapies are going to be done, what equipment you need, you know, every detail we could go over. So with my class, it's a 1-hour PowerPoint presentation, and then patients usually stay after for about 15 minutes to learn from each other's questions, and we go over everything from how long am I going to be out of work, who does the disability paperwork, can I wear nail polish, like we go over everything you could possibly ask. So there's a level of, you know, familiarity. Then I usually stay after for a couple minutes if patients have any individual questions as well. But really, when patients know what they're getting into ahead of time, it really reduces the anxiety so they can really focus on the recovery after surgery.
Right, and you want them to feel better, and you do. Dr. Marcus and Cindy Romanowski are here. We're going to talk about Cindy's book when we come back after this break. And as we go to break, we'll tell you all about where you can find out how you can connect with our guests here on your Hometown Health Connection. We'll be right back. Our conversation with Drs. Cindy and Marcus Romanowski will continue, but first get a pen and paper and write down how you can reach them. They're at General Physician PC, GPPC Knee and Hip Center, and here's that address, 705 Maple Road in Williamsville. And if you want to go online, you can find out more about them at gppconline.com. And the phone number is 716-839-0632. We'll have that number and that information later in the show because we'll be right back. Buffalo Healthy Living Magazine is a free, full-color magazine distributed throughout Western New York. Now, more than ever, as we all want our families and friends to be safe and well, Buffalo Healthy Living Magazine is devoted to health, fitness, and nutrition for people of all ages. It's a great read and also has great recipes. Pick up Buffalo Healthy Living Magazine all over our hometown or go online anytime at buffalohealthyliving.com.
I've been a physical therapist since 2007, and I've been with the VNA of Western New York since 2010. So a majority of my time has been treating patients within their home. It's really a pleasure because the patients know before they leave the hospital who their therapist will be. They've already been educated by Dr. Cindy Romanowski at the pre-surgical course on what to expect leading up to the surgery. So the exercises that the patient should be doing before surgery, what to expect the morning of the surgery, and then, you know, before they leave, they will know that either myself or one of the other therapists, they know the name of who's coming to see them, as well as we receive the contact information for the patient. We'll a lot of times call them actually and speak to them on their way home so that we can meet them at the home or the next day. It is very rewarding. In fact, some of the patients, it's interesting, and you kind of get a lot of the same comments from the patients, and you know, the day after they're like, oh my gosh, I don't know if I made the right decision. And I said, just give it a week. You just have to give it a week because right after the surgery, you might have a lot of the anesthesia and the medications still in you, the pain medications. But after a week, it's unbelievable the progress these patients have. We're transitioning from using a walker to a cane, and then at 10 to 14 days after the surgery, they're going in to see Dr. Romanowski for the staple removal. And a lot of them are going into that follow-up visit with a cane, and significantly improvement in their walking ability as well as their pain levels. Very, very very much improved. So it's really rewarding.
I started going to see the doctors in 2014. I was having problems with my knees, and they did x-rays, and Dr. Marcus told me at that time that I was not ready for knee replacements. So I started going to Dr. Cindy in 2014, and she started giving me injections in my knees, which helped for a while. But in 2020, it was just so bad. So I went back and I was re-x-rayed, and Dr. Marcus consulted with me and told me that I'm bone on bone and that I need total knee replacements in both of my knees. So I actually had my first knee done last August 7th, about 8 months ago. And after 6 months, I was doing so well with my right knee. I had my left knee done February 1st, almost 3 months ago. My right and left knee surgeries went better than I expected. And both of my surgeries were done at the Snyder Surgical Center at the ECMC complex. And it was a great place to have my surgery and a very caring staff. On both my surgeries, I came home the same day. And by the afternoon, I had a physical therapist here from the VNA. And she worked with me right away and got me moving. And Dr. Cindy has her own physical therapist with the VNA that works with her patients. And I got the same therapist for my left knee as I had for my right knee because I did so well. I feel good, but I have to keep doing my exercises 3 times a day. I mean, you don't go through exercises like that and expect it to be okay if you don't work to keep it okay. I would just recommend Doctors Marcus and Cindy to anyone. They're wonderful.
Welcome back to your Hometown Health Connection. I'm John DeSciullo. Samantha Latshaw is on assignment. We're continuing our important discussion on knee and hip replacement surgery with Doctors Cindy and Marcus Romanowski. So, Dr. Marcus, where does the surgery take place?
We do our surgeries at the Surgery Center at Erie County Medical Center. So it's on the Erie County Medical Center campus on Grider Street, but it's a separate building from the main hospital. The beautiful thing about the Surgery Center is it was designed with modern joint replacement in mind. The physical plant is unparalleled in Western New York in terms of the efficiency with which patients can be processed through the center and safely have their surgery. It gives a great option of patients have the ability to go home the same day if they wish, but they also have the option to stay at the hospital if they decide that's a better option for them.
I was going to ask that, is the follow-up for recuperation there at the facility, or is it split between the facility and home?
Well, it depends on which path the patient takes. So if a patient has outpatient joint replacement after the surgery, the therapist or the nurses will get them up and have them walk around a bit in the surgery center before their family takes them home. If the patient ends up staying overnight in the hospital, they'll actually get physical therapy in the main hospital, both the day of the surgery and the next day prior to going home. So for some patients, perhaps that live alone and have many stairs to get up to their flat or what have you, that might make more sense for them to spend a night in the hospital. But for other people who have a spouse at home or a floor plan that's easier to navigate, they can go home the same day.
You're taking all of that into consideration.
Yes, that's all. Actually, Cindy, when she does her preoperative assessment of the patient, all those things are reviewed and discussed, and the discharge plan is determined well ahead of the surgery.
Right. And speaking of patients, Dr. Cindy, I read the statistic, over 10,000 patients that you've worked with over these last several decades. And let me read you the title of a book that Dr. Cindy wrote. It's called A Patient's Guide to Total Knee Replacement: How to Achieve Your Best Possible Outcome Through Preoperative Education and Planning. So tell us about the book and what your patients say about it.
Well, I've been doing these patient education classes since 1998, and through the years, whenever patients leave the class, they say, "Oh, that was so great. I didn't think I was going to come, and I'm so glad that I came. You should write a book. You should write a book." So I finally, a few years ago, I just put it in writing. So it's basically a transcript of my class, but it includes a lot of graphs and pictures and exercises and explanations. So the patients really need to be educated before surgery. It really makes a big difference.
And we were talking before the recording of our program, you've written the book in a way that really people can really understand it very thoroughly. It's kind of a personal approach that you've had that you brought to the presentation of the book.
I just try to put myself in the patient's position. Everything we do is very patient-centered, so they're just all the questions that I would ask if I was going to be having a procedure. So yeah, I think the pictures really help quite a bit.
Yeah. So Dr. Marcus, with the book and everybody that's working together in this cooperative way, so the patient's now ready to go home. And you talk a little bit about the therapies, but how long does it take generally to recuperate from a knee surgery? Because I've had some friends who've had some surgeries, and it feels like it's taken a long, long time.
Sure.
Or does that vary based on the severity of the situation?
Yeah, it can. You know, everybody's a little bit different, but in general, patients are able to go home the same day and ambulate independently around their home using a walker or a cane. By the time we see them back at 2 weeks in the office to check the incision and assess the wound healing, we also do an x-ray at that visit. Most patients have seen a marked improvement in their functional ability. They're feeling more independent, like they can be at home alone. They don't need someone with them. And then usually return to driving is at about 4 weeks after surgery. Hip replacements usually can drive about 2 weeks after surgery. If you're having a right knee replacement, and that's your leg that you're going to be operating your brake with on your motor vehicle, usually it's about 4 weeks till you get that reaction time back. But if you want to go out to the driving range and hit golf balls, probably 4 to 6 weeks, depending on how proficient you are prior to the surgery.
I hear the term weight bearing. Does that play a role?
Well, patients can weight bear fully as tolerated right after the surgery, but there is some pain associated with that. So it's a little bit of a balance, and pain is like hair color. Everybody is a little bit different. So some people will advance at a faster rate than others, but they can put their full weight on the limb from the outset.
And this team approach, Dr. Cindy, that we've talked about, how does that work on the recuperation side? We've talked about all the prep work leading into the surgery. How does that team approach work with you when now they're home and getting back on their feet?
A big part of the prep work is having good planning beforehand. So in addition to coming to my class a month or two before surgery, patients come into our office 3 weeks before surgery and they get their pre-admission testing. So their lab work, which is required for all surgeries, the lab work is performed by my nurse, the EKG is performed by our staff, and it's, you know, one entry, not a lot of walking, and then they're going to sit down with me for 20 minutes and we really hammer out a plan. So we kind of introduce what the options are when patients come to the class, but then we decide when they sit down with me, how many stairs do you have? What kind of equipment do you have? Who's going to be with you? Do you have a spouse? Do you have a niece? So we really decide, are you going to go home the same day? Are you going to stay overnight? Or do you require more rehabilitation? So for patients who go home, I make arrangements to have one of my therapists from my team come in the house to work with patients. In Western New York, I'm fortunate to work with the VNA, the visiting nurses, and they cover all the big 10 counties of Western New York. So whether we have patients from Orleans, Genesee, Niagara, Cat County, down to the Pennsylvania state line, I can have a therapist in their house a couple of hours after they get home from the hospital. The therapists who come in the house are therapists who have actually come to my training course, and once they're on my team, they like being on my team, so they've worked with me for several years. We communicate through secure texting, so if Mark does the surgery at 9 o'clock in the morning, the patient goes home at 1 o'clock, and I have a therapist in their house at 2 o'clock in the afternoon. If they need something in the house, the therapist can text me and say, we need a different medication, and I can do it right then. So we have constant communication all the time with the therapist being the boots on the ground, and that makes a huge difference.
And using technology too to make sure everything
Using secure technology, they can get in touch with me at any time. So, and I think patients kind of know that after being in our office for several years, we're not going to leave you hanging.
Yeah.
You're going to get the care that you need as long as your therapist texts me and communicates with us. And getting them in the house the same day that they go home is really, doesn't leave room for any jitters.
It's almost as important as the surgery and everything itself.
It
just
is.
Having that confidence and that
The
peace
confidence.
of mind. So Dr. Marcus, we've talked about some of these procedures and talked about everything leading up to it, but is there something that people should know regarding the need for these types of surgeries? Maybe there is a risk involved for some people, and is that the case?
Yeah, I think everybody has to consider their other medical issues. But if you look at the million knee replacements that are done every year in the United States, statistically, your biggest risk is for blood clot. So there's a number of measures that we do to help protect patients from that. And the incidence really overall is quite low. It's less than 1% of patients will have that issue. The preoperative education, the preoperative exercises, Cindy instructs the patients from the time they wake up in a recovery room. There are ankle pump exercises and other things, isometric exercises they can do to help protect themselves from a blood clot. All patients go on some type of blood thinning medication for about 4 weeks after the surgery to protect them from that. And then there are other measures to protect from infection, slowdown in gut function, that kind of thing. So I think another big plus of the preoperative education is Cindy talks a lot about the most common pitfalls that patients can run into. And then, so we know these things are a potential risk. How do we address that ahead of time and minimize the risk as much as possible?
So I'll follow up on that. What's a common pitfall
With
any of these surgeries for knee or hip?
Well, by teaching people ahead of time and knowing what to expect, I'm actually empowering them to reduce the risk on their own.
Yeah.
So the biggest risk is probably getting blood clots, but we don't really have a problem with that because people who move don't get blood clots. And when people go home from surgery the same day, they don't have a problem with it. When patients sit down with me in the office 3 weeks before surgery, I specifically tell them exactly what medication they're going to take, because I sit down and I really go over their medical history with them, and we can actually provide prescriptions for patients. My goal for patients is when you leave the surgery center, you're going home and you're staying home. I don't want you to stop at the pharmacy. I don't want you to pick up a walker. I don't want you to go anywhere else. I want this to be all very streamlined for you and easy for you.
And it sounds funny, but you know, for example, constipation is a terrible thing. Like, you can have a joint replacement surgery, but if you get bad pain from your bowel, that can be worse. And it sounds kind of funny to talk about it associated with joint replacement surgery, but that is a simple thing that can be avoided. And that's one of the things Cindy talks about at her class. There are simple things you can do to make sure that doesn't happen. So that just makes the whole experience much easier.
I guess everything sort of comes together in some way, shape, or form.
They have everything in the house they need for the surgery before they leave for the hospital, because we spent a couple minutes on that in the class.
So I guess we'll wrap with our final minutes here. Is there something else you'd like to add, Dr. Cindy, about sort of the unique care model that you've worked on to alleviate a person's fears, no matter what their age? Because the median age we mentioned earlier is 62, but it could be any age where somebody has this happen. How would you kind of sum it up for somebody who might be watching and thinking that they might need something to happen?
I would say don't be scared to come in and just get an evaluation. We will do our work on the back end to help you with that. The patient education is really critical. If you can have an advocate with you, because it's a lot of information. It's hard being patient these days. There's COVID, there's all different protocols that are new, and I'm constantly updating my PowerPoint in my classes to accommodate for these things. I've started providing smaller classes so we can, educate people ahead of time without having too many people in the room. If you bring an advocate with you, we'll teach you everything you need to know so you can empower yourself and you can take your better outcome back into your own hands. I'll provide the therapist in the home afterwards. We do a lot of work in our office to make sure patients get what they need.
And you're alleviating the fears. You really are.
That's really the biggest thing. I think that people come into my class, are they going to show a video? Are they going to show what it is? No. I'm going to teach you what you need to do to come through this and have the best possible outcome that you can have. And I think that once we can get the jitters out of the way, people can really focus on their joint replacement, focus on the recovery. And I see all of our post-op patients at 6 weeks after surgery, and most patients who do well, they'll say to me, I just did what you said. If you just follow the plan and do what we tell you to do, because we've put so much into this over the course of many years, you're gonna have a good outcome.
To purchase Dr. Cindy's book, A Patient's Guide to Total Knee Replacement, you can do so at their office, located at 705 Maple Road in Williamsville, or online at SheridanSurgical.com, and you just click the word products. And here's the information you'll need to connect with Dr. Cindy and Marcus Romanowski. They're a general physician, PC, GPPC Knee and Hip Center. That's at 705 Maple Road in Williamsville. The website is gppconline.com, and the phone number is 716-839-0632. I'm John DeSciullo in for Samantha Latshaw. Thanks for watching. Stay safe and be well. A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.